Consider the situation where a critically ill patient is treated for a bloodstream infection that is not real. Sadly, blood culture contamination leads to this scenario more often than we would like. Good morning. My name is Irene Brumit, and today I will be presenting a pilot study aimed at reducing blood culture contamination rates in the ICU at Brooke Army Medical Center. I will cover the significance of this issue, the intervention we implemented, and the lessons we learned in our quest to enhance patient safety and improve diagnostic precision. Site or organization. Brooke Army Medical Center, or BAMC, located at Joint Base San Antonio, Fort Sam Houston, Texas. It stands as the largest Level 1 trauma center and military treatment facility within the Department of Defense, now referred to as the Department of War. It caters to active duty service members, combat casualties, military families, veterans, and local civilian trauma patients. The BAMC team is made up of dynamic groups of active duty military personnel, including physicians, nurses, and medics from various branches, as well as federal civil service staff and civilian employees, contractors, and trainees such as rotating medical residents, fellows, interns, and students. The facility has 86 intensive care beds in its high acuity area and handles approximately 2,600 adult ICU admissions each year. This high volume of admissions leads to extensive diagnostic testing, providing a rich source of pre-analytic data tracking. The Quality Improvement Initiative to reduce blood culture contamination rates was launched in 3 South, an intensive care unit focused on cardiothoracic surgery, coronary care, and cardiovascular treatment. This high acuity environment frequently requires blood draws to identify bloodstream infections like sepsis. In the ICU, blood culture contamination poses a significant risk because clinicians often start immediate intensive antibiotic treatment for suspected sepsis. Given the high acuity of care in the ICU, it is essential to minimize diagnostic errors, such as false positive blood cultures, to avoid unnecessary antibiotic use and prolonged hospital admissions. Needs assessments result. The need for a quality improvement initiative to reduce blood culture contamination at BAMC is highlighted by the large gap between current blood culture contamination rates in the BAMC ICU and the national safety standard of less than 3%. In the ICU, blood culture contamination can cause false positive results, leading to longer hospitalizations, unnecessary or inappropriate antibiotic use, and higher healthcare costs. Research from peer-reviewed initiatives conducted at BAMC indicates that traditional, non-standardized methods resulted in baseline contamination rates as high as 6.6%. Before the project, the blood culture contamination rate in the BAMC 3 South ICU was 4.7%. This suggests the ICU has specific structural vulnerabilities, particularly heavy reliance on indwelling lines and rapid implementation of sepsis, protocols which often drive contamination spikes. This evaluation provides a data-driven rationale for implementing standardized and strict peripheral collection protocols within BAMC's critical care environment. Project topic: Implementing a standardized blood culture collection bundle in the 3 South ICU at BAMC can improve diagnostic precision, reduce healthcare costs, and optimize antibiotic use. Key interventions include standardizing skin preparation through a strict 30-second friction rub and ensuring the area is completely air-dried, requiring the use of an initial specimen diversion device like the Curin lock, which captures the first 0.5 milliliter to 1 milliliters of blood that may contain skin contaminants, limiting blood culture collections from existing central or arterial lines unless specifically ordered to check for line infection, conducting peer-to-peer observations with immediate feedback, establishing mandatory personalized training sessions for all ICU staff on the Curin lock and proper peripheral venipuncture techniques, and utilizing control charts to monitor contamination rates over time while providing ongoing feedback. Project goals. Employing the SMART criteria, meaning the specific, measurable, achievable, relevant, and time-bound, is a highly organized approach. The goal is to reduce the blood culture contamination or false positive rate in the 3 South ICU at BAMC from 4.7% to below 3% over a 12-week time frame by implementing a standardized blood culture collection bundle protocol. Specific. The focus is clearly defined on lowering false positive blood culture rates, specifically in the 3 South ICU at BAMC. Measurable. A clear quantitative target is established, aiming for less than 3%, which aligns with the benchmarks set by the American Society for Microbiology, or ASM, and the Clinical and Laboratory Standards Institute, or CLSI, as highlighted by Bond and Cornish in their study. Achievable. The objective is realistic and can be accomplished by introducing evidence-based blood culture collection bundles and interventions, including strict compliance with hand hygiene, chlorhexidine skin antisepsis, precise collection techniques, optimal blood draw volumes, and the use of an initial specimen diversion device like Curin lock. Relevant. Reducing false positives significantly enhances patient safety by preventing unnecessary antibiotic use, shortening hospital stays, and lowering healthcare costs. Time-bound. The goal has a specific deadline of 12 weeks, which allows the team to assess progress monthly through quality control data. Project outcomes. This includes clinical outcomes, process outcomes, financial or safety outcomes. Implementing a blood culture collection bundle using the Curin lock passive diversion device in the 3 South ICU at BAMC improved blood culture contamination rates. Current unit data demonstrates a 4.3% rate. During the 12-week pilot period, 70 blood culture sets were evaluated with 3 contaminated cultures, resulting in a contamination rate of 4.3%. This represents a decrease from the baseline contamination rate of 4.7%, demonstrating an improvement in blood culture collection practices during the pilot period. However, the final contamination rate remained 1.3 percentage points above the less than 3% benchmark. Blood culture contamination leads to false positive results, which trigger unnecessary broad-spectrum antibiotic use, prolonged hospital stays, increased risk of C. diff infection, and higher healthcare costs. Clinical guidelines and organizations like the Centers for Disease Control and Prevention recommend maintaining a blood culture contamination rate below 3%, with an ideal target of 1% or less. The 3 South ICU introduced a standardized, multimodal evidence-based bundle. The Curin lock device was integrated into the collection process. The passive diversion technology automatically sidelines the initial 0.15 milliliters of blood, which typically contains deep dermal skin contaminants, before the actual sample is collected. After implementing the bundle and Curin lock, 3 South ICU observed a 0.4% decrease in the contamination rate. The reduction not only brings the unit closer to the national benchmarks, but also drastically limit false positive bloodstream infection. By minimizing false positives, the project reduces downstream complications, saves thousands of dollars per misdiagnosed case, and supports antibiotic stewardship by preventing unnecessary antibiotic therapy. Although the project did not achieve the established benchmark during the 12-week pilot, the reduction from 4.7% to 4.3% demonstrates a positive trend toward the desired outcome. Continued implementation of the standardized collection bundle, including the Curin lock device, staff education, competency reinforcement, and ongoing audit and feedback will be necessary to further reduce contamination and achieve a sustained rate of less than 3%. Stakeholder reception. The initiative to reduce blood culture contamination rates in the 3 South ICU at BAMC ultimately garnered strong stakeholder support and fostered a positive cultural shift within the unit. However, in the early stages, the project faced resistance from frontline nursing staff, mainly because of time constraints, workflow disruption, and fatigue from ongoing changes. When the Quality Improvement Initiative was first introduced, it faced pushback from seasoned nurses who perceived it as a disturbance to their workflow. Nurses worried that the added steps, such as thorough skin preparation, strict adherence to specific antisepsis protocols, and using a Curin lock device during collection would take time away from caring for high acuity ICU patients. Some team members believe their current collection methods were adequate, despite unit data showing high contamination rates. Additionally, the staff was already adjusting to multiple organizational changes and viewed the new, more rigorous blood culture collection protocols as yet another imposition. Sustainability. To establish blood culture collection as a permanent standard of care in the 3 South ICU, it is essential to embed the process into the unit's daily operations through the following methods. Number 1, identify key frontline nurses in the 3 South ICU to act as champions. They will provide peer support, address any challenges, and monitor the competency of new staff members. Number 2, utilize visual management tools and dashboards to display monthly contamination rates in the unit breakdown or on huddle boards. By sharing transparent data, staff remain engaged and informed about their performance. And number 3, collaborate with the supply chain to ensure that all necessary bundle supplies, such as chlorhexidine applicators and Curin lock devices, are standardized and consistently available in the automated dispensing cabinets or carts within the ICU. If sustainability efforts fail, a successful one-time implementation can still provide significant and lasting benefits for BAMC. Proven return on investment, or ROI, A contaminated blood culture can cost the hospital significant amounts due to excessive antibiotic use, increased hospital stays, and extra lab work. Showing the bundle can be effective, even for a short period, gives leadership the data needed to secure funding for permanent resources. Permanent baseline changes. Even if rates gradually increase again after the pilot concludes, they seldom revert to the original pre-intervention baseline. Staff awareness remains elevated, and previous poor practices like using IV lines instead of performing peripheral sticks are often permanently modified. Antibiotic stewardship. By preventing false positive results, even temporarily, we can avoid unnecessary patient exposure to broad-spectrum antibiotics. This directly reduces the risk of C. diff infections and antimicrobial resistance. Empowering frontline staff. This shows the nursing team in the 3 South ICU that their workflow matters and that they can implement evidence-based changes, promoting a culture of safety. My professional goals for the practicum. My practicum project focuses on implementing a blood culture collection bundle and the Current Lock device in the 3 South ICU at BAMC. My professional objectives include introducing an evidence-based practice by standardizing the blood culture collection process in order to lower contamination rates, enhancing staff competency through targeted educational initiatives for nursing personnel to ensure adherence to the new collection procedures, improving patient outcomes by reducing false positive blood cultures to minimize unnecessary antibiotic use, decrease length of stay, and lower hospital healthcare costs, and fostering interdisciplinary collaboration among intensivists, unit nurses, and laboratory staff to support the pilot study. The American Organization for Nursing Leadership, or AONL competencies. My career objectives are in line with the revised standards set by the American Organization for Nursing Leadership, or AONL. Number 1, knowledge of the healthcare environment. My project focus implementing evidence-based practices and enhancing patient safety by using the Current Lock to effectively reduce initial skin contaminants, with the desired outcome of gaining insight into the regulatory and clinical implications of hospital-acquired conditions and ensuring diagnostic accuracy. Number 2, effective communication and relationship building. My project focus, facilitating daily safety huddles and conducting educational sessions for the nurses on 3 South ICU to address resistance to a new care bundle. Desired outcome includes employing situational leadership to build consensus among stakeholders and drive desired behavior changes. Number 3, leadership capabilities. My project focus, overseeing the change process within the unit from the pre-intervention stage to pilot implementation. Desired outcome includes articulating and promoting a shared vision for quality improvement while encouraging accountability among staff. Number 4, professionalism. Project alignment. Ensuring the project aligns with BAMC's commitment to excellence in patient safety and clinical integrity. The desired outcome will be reflecting professional accountability by advocating for patient-centered decisions and maintaining ethical standards and in data reporting. Number 5, business acumen and principles. My project focus, evaluating baseline and post-intervention data on blood culture contamination. Desired outcome includes utilizing quality improvement principles to demonstrate how clinical metrics translate into financial and operational success. What I learned from the project. My practicum project centered on a critical evidence-based practice objective, which is reducing blood culture contamination rates to below the national benchmark of less than 3%. By implementing this quality improvement initiative in the 3 South ICU at BAMC, we aim to enhance antibiotic stewardship, decrease length of stay, minimize false positive sepsis diagnosis, and lower healthcare costs. As the clinical leader for this project, I gained several significant insights. Number one, the importance of multidisciplinary collaboration. I realized that reducing contamination rates is not solely about nursing education. It requires a collaborative team effort. Working together with the laboratory department, infectious disease specialists, and unit leadership was essential in identifying procedural weaknesses. Number two, the need for standardized protocols. I learned that meaningful practice changes come from standardizing evidence-based practices, implementing strict collection protocols, including consistent pre-packaged antiseptic kits, proper skin and bottle disinfection, and the current lock collection device was vital. Number three, the impact of data-driven change. Through my leadership experience, I recognize the immense value of data-driven feedback. Regularly auditing contamination rates and sharing that data directly with bedside nurses demonstrated that accountability and transparency are crucial for sustaining the project. And number four, balancing patient safety with cost management. I discovered the broader implications of nursing care. By reducing a single contaminated culture, we can prevent downstream issues such as false positive results, unnecessary use of broad-spectrum antibiotics, and wasted healthcare expenses. Now the conclusion. Blood culture contamination is an important issue that goes beyond statistics. It significantly affects patient outcomes. Strong clinical leadership and active stakeholder involvement play a crucial role in embedding evidence-based protocols into everyday practice, thereby safeguarding patients from the potential physical and financial consequences of misdiagnosis. My project focused on reducing blood culture contamination rates in the 3 South ICU at BAMC to below 3%. While we did not achieve this contamination target, we observed a measurable improvement in contamination rates, which fell from 4.7% to 4.3%. This 0.4 percentage point decrease indicates progress towards our goal and highlights the potential benefits of focused quality improvement initiatives within the ICU. The project underscored the crucial role of nursing leadership in pinpointing practice gaps, implementing evidence-based strategies, engaging staff, and monitoring outcomes. Although the contamination rate remains above the desired level of less than 3%, this improvement establishes a basis for ongoing efforts to enhance blood culture collection practices. Continued education, reinforcing standardized collection methods, offering regular feedback on contamination rates, and addressing compliance barriers will likely contribute to further reductions over time. In summary, the practicum project revealed that significant quality improvements can be achieved, even if the initial target is not entirely met. Ongoing leadership involvement, staff accountability, and consistent implementation of evidence-based blood culture collection practices will be vital for reaching and maintaining a contamination rate below less 3% in the 3 South ICU. The findings also highlight that quality improvement is a continuous journey that requires regular evaluation, adaptation, and teamwork across healthcare disciplines. And that concludes my presentation for today. The next part of the presentation is dedicated to question and answers. I'm warmly inviting you to share your questions during this part of the presentation. Your curiosity helps create an engaging discussion. The last 6 slides are the references for this presentation. Thank you.